to welcome Simon Chaturvedi. He's a wonderful colleague and international leader in our field of stroke. There's quite a bit of active discussion, particularly now in our clinical management, with the release of the CREST-2 publication. I couldn't think of a better person than Simon Chaturvedi, who's the Green Endowed Professor of Stroke at the University of Maryland. Um, and Dr. Chaturvedi has been one of the leaders in the field of carotid arterial disease management for decades. And so as soon as the paper came out, we started asking him if he could give a lecture to us. Many of you and here that are on the call have been asking about having a lecture now that that publication is out. So without further ado, Simon, please, thank you so much for joining.
Yeah, thank you, Sean, and it's a great pleasure to join everyone today. And so I was going to discuss a few different topics today. I'll definitely touch on CREST-2 and some of the highlights from the paper, but I'll discuss a few other topics also. And here are some of my disclosures. I'm going to talk about the SCORE registry, which is for symptomatic carotid disease. And I was on the executive committee of CREST-2, and then some consulting you can see there. All right, so the topics that I wanted to focus on were to go over what we learned from the landmark carotid endarterectomy studies. I'll talk about some important concepts in risk stratification, and I'll touch on modern medical therapy for carotid stenosis, and then look at recent trial data, as well as recent trial data pertaining to symptomatic stenosis, and then some thoughts for the future on how we can improve care. So if you look at the last 20, 30 years, the good news is that we've done quite a few studies pertaining to carotid revascularization. And so some of them have been versus medical therapy, others have been stenting versus endarterectomy. I hope nobody knows what all these acronyms stand for. If you know what all these acronyms stand for, then I think you need to play more golf or play more pickleball and get outside the hospital a little bit more. But these are some of the carotid trials which have been done in the past. Now, just to make sure we're all speaking the same language, we should sort of have some definitions of asymptomatic. And so traditionally in the trials, asymptomatic has meant no clear-cut TIA or stroke in the territory of the stenotic vessel in the past 6 months. And those individuals who have sort of vague symptoms such as lightheadedness or dizziness, they would not qualify as symptomatic. Similarly, syncope would not be considered symptomatic, and posterior circulation symptoms would also not be considered symptomatic. So in terms of where we've been, for those of you who have a little bit of gray hair, you'll remember that the NACID and ECST study were launched in the 1980s for symptomatic stenosis. Also, the ACAS trial was launched at about the same time. And all of these were positive to varying degrees, and this led to a sharp increase in the number of carotid revascularization procedures. And the current estimate is that if you include endarterectomy, TCAR, and transfemoral stenting, there are about 80 to 100,000 procedures in the US. Now, if you look at what is the bottom line of the previous studies, this is illustrated here, that the patients who benefited the most were those who had recent high-grade symptomatic stenosis. And so here you can see about an 8.5% absolute annual benefit on the right-hand side in those with symptomatic high-grade stenosis. In the symptomatic moderate group, the benefit was much reduced at about 1.3%. And in the asymptomatic group, there was also fairly marginal benefit at around 1% per year. Now, as I mentioned, these were conducted many years ago in the late 80s, early 90s. And so with improvements in medical therapy, if you can reduce these bars by, say, 50% or 60%, then you can see that there would be much less benefit in the symptomatic and asymptomatic groups. And even in the high-grade symptomatic stenosis, the benefit could be reduced substantially. Now, if you look at the previous combined analysis of the symptomatic trials, you can see that the absolute benefit was about 16% over 5 years for 70 to 99% stenosis. In the 50 to 69% group, there was no clear benefit, or it was a marginal benefit at around 4.6 over 5 years, no clear benefit below 50%. And then in the near occlusion, or the so-called string sign group, interestingly, those patients also did not have clear benefit. Now, another important factor to consider is how long after the last symptomatic event are you seeing the patient? And so here, this is analysis by Dr. Rothwell and colleagues, where they looked at the weeks from the last symptomatic event to the time to entry into the trial. And you can see that the longer you go, there is declining benefit from performing revascularization. And in fact, for the 50 to 69% group, there was only benefit for about 2 weeks after the last symptomatic event. And in the high-grade stenosis, also you can see declining benefit, but that persisted for about 12 weeks. As a result of this analysis, you may be familiar with the fact that many guidelines now recommend revascularizing earlier rather than later. And if the patient has a non-disabling stroke, then doing it within 2 weeks is recommended. Now, what about in terms of deciding between revascularization and medical therapy? So here the trials did give us some important information regarding subgroups. And so one of the interesting observations is that patients with retinal events, such as amaurosis fugax or central retinal artery occlusion, they tend to have reduced stroke risk. So that would favor medical therapy. Also, women patients have less benefit from revascularization, so that would also favor medical therapy. If the last event was more than 2 weeks ago, that would have a lower stroke risk, so that would favor medical therapy. If you have severe comorbidity, and if you're concerned about, say, 2, 3, 4-year life expectancy, then that would favor medical therapy. If you have positive emboli on transcranial Doppler, that would favor revascularization. And then at the end, I'm going to talk about intraplaque hemorrhage on MRI. If you have intraplaque hemorrhage on MRI, that's associated with an elevated risk of stroke, so that would favor medical therapy. Absence of intraplaque hemorrhage would favor medical treatment. Now, also in Dr. Rothwell's analysis, they calculated the number needed to treat in different strata. And so you can see the significant difference between men and women, that you needed to operate on 9 men to prevent 1 stroke compared to 36 women. And then also if you operate in delayed fashion, greater than 12 weeks after the last symptomatic event, you can see an astronomical number, whereas it's only 5 if you operate within 2 weeks. Now, the observations on age were interesting because those individuals who had over age 75 had greater benefit compared to younger patients. But the caveat is that the NASIT study was very restrictive about the older patients who were allowed in the trial. And patients with significant heart problems or limited life expectancy or COPD were not allowed in the trial. And so this was really a very healthy elderly group. And also there were very few patients over age 80 enrolled in the trial. Now, in terms of timing of revascularization, one tool that I've used in recent years is the so-called 1-3-14-28 rule, whereas if the patient presents with a symptomatic TIA and you feel they're a good candidate for revascularization, try to do the procedure early. And if it's a mild stroke, within 3 days. If it's a moderate stroke, within 14 days. If it's a more severe stroke, then I would reevaluate them at 28 days and see what the extent of neurologic recovery is. If their functional status is not that good, for example, 4 weeks later, if they still have global aphasia and right-sided hemiplegia, then I would probably not revascularize at all because their functional status is quite poor. Now, in terms of the advances in medical therapy, we've learned a lot from the studies of intracranial stenosis and especially the SAMPRAS trial. And so when Dr. Chimowitz and colleagues looked at the rates of stenosis, rates of stroke rather, in patients with high-grade stenosis in the intracranial vessels, they found interesting observations. And most of you know about the Sampras regimen for management of symptomatic intracranial stenosis, including dual antiplatelet therapy for 90 days, targeted reduction of blood pressure, and targeted reduction of LDL to getting it to less than 70. And then also Sampras used the Intervent program for lifestyle modification. And so you could easily use all of these elements for extracranial disease also. And so that has been done to some extent in CREST-2, but it's never been applied in a large-scale symptomatic carotid stenosis trial. And so here you can see that there's no reason why you couldn't have sort of a Sampras version for extracranial disease. And these days we would even target an LDL of less than 55 based on the new ACC-AHA lipid guidelines, which came out a few weeks ago. And just to illustrate how old the prior studies were, this slide shows the rate of statin use in previous trials, and you can see that it was very low in NASCET, and even in one of the larger asymptomatic trials, ACST, the rate of statin use was less than 40%. Okay, so now many of you know that there have been tremendous advances in medical therapy, and so none of these were really available at the time of NASCET, except high-dose aspirin, which was used in NASCET. But now we have clopidogrel and ticagrelor as newer antiplatelet agents. We have a variety of high-potency statins. We have the GLP-1 medications for treatment of diabetes or obesity. We have the increasing recognition of the benefits of physical activity. We have trials showing the importance of dietary modification and the benefits of the Mediterranean diet. If you really want to crush the LDL to less than 40 or less than 25 even, you can use PCSK9 inhibitors. And then at the stroke conference in February, we heard about asundexian, which is a factor 11A inhibitor. And this was found to reduce stroke without increasing bleeding. And so this could also be very useful for patients with symptomatic carotid stenosis or intracranial stenosis. All right, so now let's take a deeper dive into asymptomatic stenosis. And so picture this, that you're in the outpatient office and you referred a 78-year-old man who was referred after a carotid duplex found 80 to 99% right ICA stenosis. Doesn't have severe disease on the other side. The risk factors you can see there, no previous stroke or TIA. And he plays golf regularly, so pretty active. LDL you can see there. And so the question is, based on this duplex, would you do further testing? Would you do a CTA? Would you do an MRA? If you have it available, would you do transcranial Doppler with emboli detection? And then what would you recommend in terms of treatment? Would you recommend intensive medical therapy, or would you recommend revascularization plus medical therapy? So here we have some new information pertaining to the CREST-2 study, which was presented and published recently. And just to review, the main goals of the CREST-2 study were to look at, in two parallel trials, individuals with 70 to 99% asymptomatic stenosis. And so the first trial looked at intensive medical therapy versus endarterectomy. And then the second trial looked at intensive medical therapy versus carotid stenting. And so here you can see the design of the two parallel trials with the overall goal of having about 2,500 patients. But at each site, you could decide which trial you wanted to enroll the patient in, either in the stenting arm or the endarterectomy arm, based on the patient characteristics. Here are some of the key exclusions. And there were many exclusions, over 30 actually, but here were some of the key ones, including significant renal disease, a low ejection fraction, poor functional status at baseline, imminent surgery, as well as atrial fibrillation. Now, one of the key components of CREST-2 was that medical therapy was centrally directed, and there were explicit goals for blood pressure control to try to get it less than 130 systolic, and LDL goal of less than 70. And you can see that the trial was fairly successful. At the final paper, about 70% of the patients achieved the blood pressure target, and about 70% achieved the LDL target. Some of these other targets were not as successful, including weight, but toward the end of the trial, there was more availability of GLP-1 medications, but they were not used in widespread fashion. So the good news, which some of you may have seen, is that the paper was finally published, and it was published online in November and then in print in January. And so let's review some of the key takeaways. And so in terms of it's important to recognize that the patients were carefully selected, but also there was credentialing of the interventionalists and the surgeons. And so if you applied as a stenter, you had to have greater than 25 cases in the last 12 months and a documented low complication rate. And this is important that only about 50% of those who applied were accepted. And so some of them were put on sort of a probation period where they could do some more cases and then qualify. But initially, only about 50% were accepted. There were also some anatomic exclusions, including long lesions, severe tortuosity of the vessel, and a difficult aortic arch. For the surgical management, here were the criteria that you can see there. Once again, they had to have a documented low complication rate, and out of the surgeons who applied, greater than 90% were accepted. In terms of the characteristics of the patient, you can see that both groups had an average age of about 70 to 71. CREST-2 had some special efforts to try to increase the enrollment of women, which was fairly successful. And so you can see the enrollment of women was about 35 to 39%, which was higher than most previous trials. About 40% of the patients had diabetes and very high rates of hypertension and dyslipidemia. Now, hopefully you can see this well, but and there'll be another slide which goes over this. But in terms of the main results of the trial, you can see that in the stenting arm, the combined primary endpoint rate was 6% with medical therapy alone, compared to 2.8% with stenting. So a 3.2% absolute difference, which was statistically significant. In the endarterectomy arm, it was 5.3 versus 3.7, which was not statistically significant. But one of the key points is that the peri-procedural complication rate was low in both the stenting and the endarterectomy groups. And so it was 1.3 in terms of peri-procedural stroke or death with stenting and 1.5 with endarterectomy. And if this complication rate had increased to 1.8, which is still many would consider excellent, then there would no longer be any benefit in the stenting arm. Here you can see in graphical terms what the previous table showed, a 3.2% absolute difference, which was statistically significant. And then for the endarterectomy portion, 1.6% difference, not statistically significant. Now, in terms of, there were many subgroups which were looked at, and two of them stood out. One was the peak systolic velocity on carotid duplex. And so in those individuals who had a very tight stenosis and peak systolic velocity of 342 or greater, then there was benefit in the stenting arm to a larger degree. And then the second subgroup was pertained to diabetes, that the patients who were non-diabetic had benefit of stenting compared to those who were had evidence of diabetes. Now, at the ISC conference in February, Professor Ron Lazar also presented the cognitive outcomes of CREST-2, and this was tracked to look at whether there was any benefit with revascularization compared to intensive medical therapy. This paper hasn't been published yet, but Dr. Lazar commented that there was no benefit of revascularization for the cognitive outcomes. And so there was a lot of interest in terms of whether revascularization would improve cognition and memory, but that was not apparent in CREST-2. And this was certainly the largest trial to ever look at the topic of cognitive outcome after revascularization. All right, so what have been some of the reactions in the months since CREST-2 has been published? Well, first of all, those who have performed stenting are quite happy, and I think they're very enthusiastic that they've been performing stenting for decades, and now they feel that they have a large clinical trial to show some benefit relative to medical therapy. Some US surgeons are certainly disappointed with the endarterectomy results, but some of these surgeons have now migrated to TCAR, and even though TCAR wasn't studied, they feel that the results can be extrapolated to TCAR. The rates of endarterectomy have been declining, and in some studies, TCAR now represents 1 out of 4 revascularization procedures. If you were a proponent of intensive medical therapy before CREST-2, then I think there's a lot to make you happy in the results. You can say that the benefit was fairly narrow. And then, as I mentioned, if there were just a few more events in the stenting group, even that benefit would have been wiped out. And then others have concerns about the external validity and the generalizability in terms of the select patients and the fact that the interventionalists were highly credentialed. And if you look at the editorial in the New England Journal, they sort of had an interesting take. Professor Brown and Bonatti commented that if you have 100 patients with asymptomatic stenosis and you treat everybody with intensive medical therapy, only one or two will have a stroke, and they'll have a non-disabling stroke. And you can always do revascularization after the non-disabling stroke. And so that was sort of an interesting take on the data. In terms of the external validity, some have had concerns about whether the low complication rate can be seen in real world practice. And I think that is a valid concern, because if you look at ACST2, which was a large trial in Europe, they found a periprocedural complication rate of close to 4% with stenting and 2.7% with CEA. And so this does illustrate that in another large trial, the complication rates were significantly higher than was seen in CREST-2. If you look at international practice patterns, you'll also see quite a bit of variability. In the US, about greater than 80% of revascularization procedures are done in asymptomatic patients. In Canada, it's about 30%. And in Denmark, they never revascularize. And so that's interesting that even though we all have access to the same data, there's been quite a bit of variability pertaining to clinical practice. So in terms of practical advice, these are some things that I sort of do in my practice. First of all, I like to use transcranial Doppler with microemboli detection for risk stratification. There have been several trials showing that those with positive for emboli have a higher stroke risk. And if you're negative for emboli, then the stroke risk was less than 1% per year. If I'm going to consider revascularizing an asymptomatic patient, I would more likely recommend it for a male patient, more likely for somebody less than 70, and more likely for very severe stenosis, and especially if the peak systolic velocity is greater than 342, as was seen in CREST-2. I'm not enthusiastic in general for patients over age 80, also not enthusiastic for patients with AFib, definitely not for patients with dementia, and then definitely not for patients with life expectancy less than 5 years. And for these other groups, I'm not saying that I would always recommend revascularization, but at least I think it's worth having a conversation for some of those, for patients in those groups. Now, also, I was on the 2024 guideline committee for primary prevention for the AHA and ASA. And here you can see that our committee in 2024 recommended that routine screening for carotid stenosis is not recommended. And then for revascularization, it gave a relatively weak 2B recommendation that the use of revascularization may be reasonable to reduce the risk of stroke, but it was certainly not a strong recommendation. I think after CREST-2, it's potentially possible that maybe this would get upgraded to 2A for carotid stenting, but I think that would probably be the maximum level that it would be upgraded to. Right, so now let's shift to talk about a little bit on symptomatic stenosis. And so this is a case scenario of a 72-year-old woman who presents 2 weeks after a TIA, and she has a left-sided weakness and 80% right internal carotid artery stenosis. You can see the medications there. And so the question is, would you recommend endarterectomy or stenting or TCAR? And would you say, or would you intensify her medical therapy? And would you say that she's failed maximal medical treatment? So this is an area that I've been interested in for many years. And this was, I think, back in 2013, where I wrote this article that medical therapy alone is reasonable for certain patients with symptomatic carotid stenosis. But I guess that was so controversial that the only place it could be published was in the section called Controversies in Stroke. But when we look at symptomatic stenosis, we need to keep in mind that the data are quite obsolete, and that if you look at the practices which were prevalent at the time of NASCET, none of the things that we commonly use these days were available at the time of NASCET. There was certainly no dual antiplatelet therapy, blood pressure control was suboptimal, and there were no high-potency statins available in the first part of the NASCET trial. So one question is, how many years has it been since medical therapy has been evaluated for symptomatic carotid stenosis as part of a North American randomized trial? And here are some options. And if people want to put their answers in the chat, I'll pause for 30 seconds or so. Okay, so we see one vote for 30 and another saying question of 35. Okay. So relative to the initial results of NASCET, it's been 35 years because the initial results of NASCET were published in 1991. So why should we study symptomatic patients? And here, because it's been a long time since the initial results of NASCET, and we know the medical therapy has advanced significantly since then. The surgical results have also improved, and also we saw the spectacular success of multimodality therapy in Sampras. And so here, this shows some other cultural events showing the differences between 1991 and the current day, including the fact that this was 16 years before the introduction of the iPhone. And if any of you go grocery shopping tonight, I doubt you would buy a carton of milk with an expiration date of February 1st, yet we're still treating patients based on 30 to 35-year-old data when it comes to symptomatic stenosis. So to try to get some data on modern outcomes, we've launched the SCORE registry. And in the SCORE registry, we have multiple sites in the US and Canada where we're trying to look at symptomatic patients who have a variety of lower risk clinical and radiologic criteria, which I'll go over in a minute. And our hypothesis is that the 1-year risk of stroke will be less than 5%. In terms of the criteria, for clinical criteria, we have those with retinal events only, such as amaurosis or CRAO or branch retinal artery occlusion. Any woman is eligible, and then those with their last stroke or TIA more than 1 week ago. For the radiologic criteria, we have absence of microembolic signals on TCD, absence of intraplaque hemorrhage on MRI, and then those with a TIA with negative diffusion weighted imaging. All of these would be thought to be associated with a reduced risk of stroke, and so we felt that these patients were appropriate to treat with intensive medical therapy only. And so just to illustrate a few patients who have been enrolled in the registry, this was a patient that we enrolled at University of Maryland who presented to emergency room with a central retinal artery occlusion one day previously. He had about 70% carotid stenosis, and you can see some of his medical data there. And so he was enrolled in the registry for intensive medical therapy only, and he did well during the 12-month follow-up period with no further events. This is another patient who was a 65-year-old who had a TIA 3 weeks ago, which had a small lesion on diffusion weighted imaging. And he was also enrolled. And then this was another patient from our center who was a 74-year-old woman who had a left MCA stroke and tandem occlusion. The intracranial occlusion was treated with thrombectomy, and then the interventionalist performed a angioplasty on the way out, and there was a residual 65% stenosis. And the patient, there was some discussion about should she have revascularization, but her functional status wasn't that great. And so finally, it was decided to treat her medically, and she was enrolled in SCORE 3 weeks post-stroke. Now, for patients in the SCORE registry, we're recommending that the sites go above and beyond Sampras. And so we want them to be extra aggressive with regard to LDL. And so we recommended a LDL target of less than 55. And if the patient was very high risk, then less than 40. The registry was pragmatic. And so the local site could determine whether they wanted to use 21 or 90 days of dual antiplatelet therapy. We were recommending 90 days if there was no contraindication, but each site could decide their own practice based on their individual patient characteristics. Here you can see some of the 18 sites involved in the US and Canada. Right now, we've completed enrollment of 114 patients, and the follow-up is going to continue through September. And so we will hopefully have some results at the end of this year regarding the results of the SCORE registry. Another interesting study pertaining to symptomatic disease came from Denmark, and this was published in Stroke last year, the so-called CASCOM study. And in the CASCOM study, they looked at 109 patients from a vascular surgery clinic with good representation of stroke and TIA. And you can see about 40% had 70 to 99% stenosis, 50 to 69 had 60% stenosis. And they used something called the CAR score. And the CAR score includes many of the relevant clinical variables such as age, sex of the patient, degree of stenosis, when was the last symptomatic event, and other factors. And they found that if the CAR score had a projected stroke risk of less than 20%, then the stroke rate was 3.1%, and it was 23 if the CAR score was greater than 20. And so this indicated that the CAR score can be clinically useful in differentiating high risk versus lower risk patients, and that some of these patients could do well with intensive medical therapy alone. And these are some conclusions from the CASCOM study suggesting that modern best medical therapy has significantly reduced the risk of stroke even in symptomatic patients. And then finally, the last topic which I wanted to address was the need to incorporate modern imaging into some of our future trials. And there have been some very interesting observations about the value of carotid plaque imaging on MRI. And this was a study from the United Kingdom where they looked at symptomatic patients, and they looked at the presence or absence of intraplaque hemorrhage. And so here you can see in the upper left an example of a patient who doesn't have any intraplaque hemorrhage. And in the other panels, you can see varying degrees of intraplaque hemorrhage. In the lower left, you can see this focal eccentric area, and here a larger area on the lower right. And so intraplaque hemorrhage is going to be bright on the MP RAGE sequence. And so this is can be easily done at your hospital when you do an MRA. And so you can add the MP range sequence onto it to look for the presence of intraplaque hemorrhage. And so what is the clinical utility of doing this? Well, in this study from the United Kingdom, they found a very starkly different stroke rate in the presence or absence of intraplaque hemorrhage. In this fourth column, you can see that the patients who were positive for intraplaque hemorrhage, they had a 23% risk of stroke compared to less than 1% in those who are negative for intraplaque hemorrhage. And so this suggests that it can be very useful in terms of giving some prognostic information in addition to the degree of stenosis. So at the ISC conference this year, I had the honor of receiving the Sherman Award. And so one of the points I made in the Sherman Award is that we need to sort of have a new framework where we need to advance beyond simply stenosis. We've been using stenosis for 30 to 40 years, and it's served us relatively well. But now with the advent of modern imaging, I think we need to consider the IPH status along with the degree of stenosis. And so if we do that, and if the patient has high-grade stenosis, plus they're positive for intraplaque hemorrhage, then you would see that these patients strongly need revascularization, and they would be at the highest stroke risk. On the other hand, if you're symptomatic with 50 to 79% stenosis, and you're negative for intraplaque hemorrhage, it's possible that you could do well with medical therapy. And I would suggest that these patients should be part of a randomized trial comparing intensive medical therapy versus revascularization. All right, so just to wrap up, what are some of the trends and controversies that we see at the current time? First of all, most procedures in the US are done on asymptomatic patients, even though these patients benefit less compared to symptomatic patients. We also see a lot of international variation, and I illustrated the difference between Denmark and the US, and so there are other international differences as well. Also, CREST-2 has been published, and so what message will it provide in the next 1 to 2 years? It'll be interesting to see whether there's a surge in stenting based on CREST-2 and whether there's a further decline in the relative performance of endarterectomy. For symptomatic stenosis, we're treating patients based on data which is very old and some would consider even obsolete. And our cardiology colleagues, I think, would find this hard to believe. And then another important point is that are we really providing adequate informed consent if we have data which is extremely old? And so in terms of trying to improve our care, I think in the future we should have so these as some of our goals to try to update the database, especially pertaining to symptomatic stenosis, and that we need to have more representation of the elderly and women, and we need to improve our informed consent and study modern imaging tools. And by doing all of these things, in addition to having faster, simpler trials and increasing the representation of women and the elderly, hopefully that will allow us to provide better care in the future for patients with symptomatic and asymptomatic disease. So I'll stop there, and I'll be happy to entertain any questions. Yes, I see one question in the chat. Let me just pull it up. Yeah, are there any thoughts on why TCAR wasn't included in CREST-2 and any future RCTs that will include TCAR? Yeah, let me. Okay, so yeah, so that was discussed during the course of CREST-2, and there was some discussion with NINDS about whether TCAR could be included in the trial. But at the time that TCAR started to ramp up, the trial was about 75 to 80% of the way completed in terms of enrollment. And so therefore it was felt that it was sort of very late in the trial to make a major change in the protocol. And also if there had been, say, a few complication rates with TCAR, there would have been sort of an uproar saying that why did you include this? And this was sort of sabotaging the trial. And so in general, it was felt that it was not wise to include TCAR late in this performance of the trial. In terms of future RCTs, I'm not aware of any at the current time. And so TCAR has been studied in registries. And so there was one registry in the stroke journal called Roadster 2, but that was relatively small. It didn't have a huge number of symptomatic patients, and so it wasn't ideal. But I am sort of skeptical as to whether there'll be any future randomized control trial that will include TCAR.
Are there other questions? Oh, good. Here's another one.
Yeah, the question was, what about the use of distal protection devices in CREST-2? Yeah, so that was mandatory. So everybody in CREST-2 in the stenting arm should have received distal protection. In terms of the particular stents, any FDA-approved stent could have been used in CREST-2. And so that was one of the differences between CREST-2 and some of the other trials. In some of the other trials, which were industry supported in the past, you had to use one particular stent in the trial. And so here, any FDA-approved stent could be used, and distal protection was mandatory. Okay, Dr. Grata says the periprocedural rate of ipsilateral stroke was negligible, so unlikely that TCAR would be better. Yeah, no, I totally agree with that. Yeah, and as I said, the results of stenting and endarterectomy were excellent in CREST-2, 1.3 and 1.5%. And so you're not going to be able to do much better than that at your hospital. And so I agree that it's unlikely that TCAR would be much lower than that.
Other questions? I think Farzan has a question.
Hey, thank you for the great lecture. Have you seen any increased rates of intracranial hemorrhage with pushing these LDLs below 40? Or I know this is kind of that theoretical risk, and I always wonder what you do when these patients come in with an LDL of 20 and intracranial hemorrhage. I know it's unrelated, but kind of adjacently related.
No, it's actually totally related because, as I mentioned in SCORE 2, and we are asking the sites to, in the SCORE registry rather, we are asking the sites to push the LDL lower, and we're asking them to use less than 55, and then if the patient is very high risk, less than 40. And there have been some trials that you may be aware of in the cardiology literature. The one which is most prominent was the Fourier study, where they used the injectable PCSK9 inhibitors, and they pushed the LDL down to around 25. And there was no increase in cerebral hemorrhage and no increase in cognitive side effects. And so, but there were very few patients with stroke, and definitely not patients with recent stroke. And but there is an increasing literature. And so, for example, in China, they're very interested in the use of PCSK9 inhibitors for symptomatic intracranial stenosis. And they also have not reported an increase in brain hemorrhage with the early use of PCSK9 inhibitors. And so I think you're going to see more widespread use. Hopefully, the cost will also come down in the next few years. But we've not, thus far, the studies, primarily in the cardiology literature, have not shown an increase in brain hemorrhage. If you're interested in further reading on that, Larry Goldstein was the lead author of a AHA scientific statement on intensity of lipid lowering and potential relationship to brain hemorrhage. Next, one question on, are there any cases where you favor Brilinta over Plavix? So I think the differences thus far have been somewhat marginal. There was one interesting analysis by Dr. Amarenko where he published that for patients with atherosclerotic stroke, there did appear to be significant benefit of ticagrelor over clopidogrel, or sort of enhanced benefit with ticagrelor. And so we do the genotyping fairly frequently to see if the patient is a poor responder to clopidogrel. And in those cases, we may use ticagrelor if it's practical to use it in the patients. And but I would say that the lion's share of patients are still on aspirin and clopidogrel. And one question on, could we further stratify asymptomatic and symptomatic carotid stenosis by intravascular OCT? I think that's an interesting concept. Maybe that would be a good pilot trial. But yeah, I think that's probably a little bit away from sort of being a large trial, but that's something that could be useful as maybe a phase 2 exploration.
And Seema, Jim had one more question, which was, are you proposing a new randomized trial for symptomatic carotid stenosis?
Oh, yeah, yeah. I am actually, and I'm working with Colin Durdane and Sham Prabhakaran and several neuroradiologists and other neurologists. And we have received approval from StrokeNet to submit a trial. We're calling it the COMMIT trial. And we're trying to look at the patients who I highlighted in that table, where we're looking at, where we're asking the sites to perform MRI plaque imaging on the symptomatic patients at their site. And then if the patient has 50 to 79% stenosis and are negative for intraplaque hemorrhage, then we're proposing to randomize them to intensive medical therapy alone versus medical therapy plus revascularization. And so keep your fingers crossed. Hopefully it'll be positively reviewed. And because I think we do need to move beyond the old NACID data. And if we could incorporate the modern imaging in a trial, I think that would be very innovative. That's never been done thus far in a symptomatic trial to include plaque imaging. And so hopefully we can get a positive review for our proposal.
So is that Seema, is that the main stratification criteria, is intraplaque hemorrhage? What about the other points you made about retinal events and time elapsed since the last spell, as to whether those might also be randomizable patients?
Yeah, no, yeah, thanks, Jim. No, I think we'll certainly stratify on some of those features. We're proposing like a phase 2B study. And so where our sample size is 365 patients. And so we won't have a huge sample to look at, like a very granular look at some subgroups. But we're open to taking any symptomatic patient in the last 30 days. And so that's sort of one other change that we want to make, is that a lot of the previous trials enrolled people up to 180 days, and we wanted to include patients with 30 days, because I think these days clinical teams and clinicians make decisions earlier, and so I think it would be more useful to include patients who are symptomatic in the last 30 days.
Some more comments?
Yeah, one question on, does the presence of contralateral ICA occlusion change the plan for asymptomatic stenosis? Yeah, that's been debated over the years. And if you go back to ACAS, they looked at that issue in the ACAS trial, and they did not find that the patients had any increased benefit if there was contralateral occlusion. In fact, in ACAS, the medical patients did slightly better. And so that raised the issue of, if there's contralateral occlusion, is there sort of greater stimulus for collateral flow, and so so in general, that does not hugely change my practice. I guess you could say if one side is 80 to 99 and the other side is occluded, and especially if there is not great flow in anatomic areas within the circle of Willis, maybe that would push you toward revascularization. But also there could be higher periprocedural complication rate in that scenario as well.
There's a prior question that came through about acute lacunar stroke and carotid artery stenosis more than 50%. Do you consider this asymptomatic in your clinical practice?
Yeah, no, that's sort of another controversial area. In the NASCET study, those patients were included. And so if you had a small internal capsule stroke and there was greater than 50% stenosis on the same side, you were considered symptomatic. But they found, not surprisingly, that the patients with lacunar stroke had less benefit from revascularization compared to patients with non-lacunar stroke. And so, yeah, I think that sort of is maybe another good area for TCD with emboli detection. And if it looks like a typical internal capsule stroke and in somebody with a lacunar stroke profile, then you could say that they're sort of quasi-symptomatic, but it would sort of reduce my enthusiasm.
Okay. More questions or comments from the group? So Simon, I guess I'll ask mine, which is, so, I mean, the registry is very intriguing. It makes me think, there's an opportunity that you're providing if you don't want to commit them to revascularization. And so I was just wondering, is that study still open for more sites, or are you winding down? And where are you going with that work?
Yes, at the current time, the enrollment is complete. And so, yeah, we enrolled 114 patients at 18 sites in North America. And so the follow-up is going to continue for till September, and then we're going to hopefully present the results after that. We were hoping that it would sort of build some interest in the area of trying to have a look at modern medical therapy for symptomatic stenosis. And so that, I think, also hopefully will give some support to the proposal that we have going through StrokeNet. And but we don't have final results yet of the SCORE registry.
One more question. It looks like Ty from Dallas wondering about CEA still being superior to stenting in the long term.
Most of the studies are showing that once you get beyond the peri-procedural period, that the two procedures are fairly comparable. And so when you look at some of the previous analyses, such as the long-term results of CREST-1, for example, the two procedures were pretty similar beyond the peri-procedural period. And so, yeah, so I don't think we could necessarily say that CEA is superior to stenting in the long term. There could be some differences in restenosis, for example. Some studies show slightly higher rates of restenosis with stenting compared to CEA, but most of the restenosis is asymptomatic. And yeah, so I wouldn't necessarily say that we would say that CEA is superior.
Okay. Ty, you have one more question? Is that...
Yes, thank you. Thank you for the talk. Had another question. I think don't want to type a lot. So basically, I think nowadays there's some evidence suggesting the revascularization within 2 to 7 days after the has a better outcome compared to the 2 weeks window that was proposed in the guideline. I think not too early, not too late, but within 2 to 7 days, we do the revascularization. And also, a lot of people presented with small mild symptoms of TIAs. They get loaded with aspirin Plavix in the emergency department, and then some surgeons do not perform CEA on top of Plavix. They sometimes create a dilemma. They want to hold Plavix, do the procedure for CEA, and then you kind of want to discontinue the Plavix and put the people at risk per the point chant protocol.
Yeah.
So how do you kind of solve those kind of dilemma in the practice?
Yeah, I guess the quick answer is that I try to find a surgeon who's comfortable operating on aspirin and clopidogrel. And I think that might be somewhat generational. I find that a lot of the younger surgeons, like those who are less than age 50, are comfortable operating on dual antiplatelet therapy. And at our center, they are definitely comfortable. And so we don't necessarily have to hold clopidogrel before doing the procedure. And but the other interesting point that you sort of raised is that there have been earlier studies showing that if you operate within 7 days compared to stenting, that the stenting group had a higher complication rate. And so that did actually make it into the 2021 symptomatic guidelines, that the higher complication rate with stenting, it was around 8% with stenting compared to 1.3 with endarterectomy for patients who were intervened on within 7 days. And so the 2021 guidelines said that if you plan to revascularize within 7 days for a symptomatic patient, then CEA is preferred over stenting. And I guess maybe what, yeah, I guess one maybe final question was any particular reason for 80 to 99% stenosis versus 70 to 99? I'm not sure exactly what that's referring to. Was that?
Yes. Hi, this is Mark Johnson. I'm from Dallas as well. Was this related? I think in your SCORE trial, you had, if I recall correctly, you had divided it that way. Was there a particular reason for that?
Yeah, so in the SCORE registry, we're including 50 to 99% symptomatic stenosis. But within that range, each site can decide who they want to enroll. We sort of expect that about maybe 60 to 70% of the patients will be in the 50 to 69% group, and then the rest will be in the 70 to 99% group. And but in that little table I showed in the trial we're proposing to NINDS and to StrokeNet, we used 50 to 79 because we thought that that if we restricted to 50 to 69, then it would be challenging to find enough patients to enroll within such a narrow strata. And so that's why we wanted to expand it to 50 to 79.
Thank you.
Sure.
Okay, it's been great. Lots of great questions. I think we've come to the end of the hour, and really thank you so much, Simon. It's when we talk about filling out that survey and is this going to change your clinical practice, I certainly say yes for myself when you see a lecture. Really appreciate your time and your expert, very comprehensive analyses of carotid stenosis.
Okay. Yeah. Thanks for the opportunity and also for the great questions. Thanks again.
Take care.
Thank you.